We're here at the 22nd CROI. My name is Fred Scheich with IFARA, and we're here with Joanne Stekler, who is Associate Professor of Medicine of the University of Washington, the host site, so the host person, kind of, in a way, and we appreciate you being here for this. It's an understanding the science of AIDS, and in this case, PrEP, so that the community will understand about the uses and the application of PrEP and be more informed. I think that's what we're trying to do here today, is get the public more informed. So Joanne, without further ado, I'll turn it over to you.
Thank you. Thank you very much for inviting me to have this conversation with you about PrEP and trying to help people to understand PrEP a little bit more. Mm-hmm. Just before I start off, I have a few disclosures. One is that I have no personal financial conflicts of interest, but also that sometimes we're going to talk about medications used for PrEP that may not be FDA approved or non-approved uses of Truvada, the medication that is currently approved for PrEP. Mm-hmm. So just very quickly, we're going to talk about PrEP, pre-exposure prophylaxis for HIV infection, and go through some of the basics. What is it? How does it work? Who is it for? Is it safe? And a few other questions that many people often have as they're thinking about whether PrEP is right for them. So the first question is, what is PrEP? What is HIV pre-exposure prophylaxis? And the short answer that we often give is it's HIV medicines for HIV-negative people to try and prevent them from getting HIV infection. And there are a couple of things that people are confused about. One is the difference between PrEP, pre-exposure prophylaxis, and PEP, post-exposure prophylaxis. And what you see on the slide is the first PEP, or post-exposure prophylaxis, is given to someone after they've had a single exposure to HIV, and they take HIV medicines for 28 days after that exposure, and then they're done. What we're talking about today, in general, is daily PrEP, or pre-exposure prophylaxis. This is for people who have frequent and repeated exposures to HIV, and they want to be taking PrEP every day to basically cover them for the periods that they might be exposed. There's been a lot of interest and some recent news from this conference about intermittent PrEP, which is for people who may have infrequent and predictable exposures to HIV.
Susan Bookbinder calls that seasons of love.
Or your cruise that you might just choose to go on. We've been talking about medicines to prevent HIV for years. And it wasn't until we had a HIV medicine that was easy to tolerate that people were really able to think about implementing this on large scale. And what you see on the slide is all of the studies that have been published to date looking at HIV pre-exposure prophylaxis. The first of these studies came out in 2010, and the last of them, I believe, last year or the year before. Again, lots of other studies being presented at this conference here at CROI. And what you see on this very busy slide is that each of these studies had a range of whether the study worked or not. From some of the studies that didn't work at all, that were done in women in Africa, to some studies that reported protection of upwards of 75%, and at this conference, numbers that are even higher. The reason for this, why there's been such a range, is what you see on this slide. It's about whether or not people took their HIV medicines or not. And this slide is ordered, so at the top is the study that published the greatest efficacy, the greatest benefit of PrEP. And in the right column here, you can see in the group that had their blood drawn for medicines, that they also had the highest number of those participants actually had blood levels detected of the medicines.
Seems to be a correlate.
It's a correlate, exactly. Mm-hmm. And for people who like their information more as figures and not as numbers, what you see on this slide is an arrangement of all of the studies that were effective on the x-axis, the bottom axis, mapped along whether or not people took their medicines on the y-axis, on that left axis. And there's a really nice line. And then finally down here are the studies that didn't show effectiveness. And what turned out is that people weren't taking their medicines. Mm-hmm. So the bottom line, the punch point is PrEP works probably even better than that 70% number if people are taking it. And PrEP doesn't work if people aren't taking it. So the FDA, the US Food and Drug Administration, approved Truvada, which is a combination medicine of tenofovir and emtricitabine, to be taken every day. And this was the first medication of its kind that would be approved for this indication. The CDC, the Centers for Disease Control and Prevention, very soon after put out some guidance for providers in order to how to help people prescribe PrEP. Initially for men who have sex with men, who represent the group at greatest risk for HIV here in this country, as well as for heterosexual men and women. These interim guidance have been replaced with a more updated guidance that I include as a reference at the very end of this. But there's been a lot of interest recently about whether or not people need to be taking their medicines every day. And specifically one study called iPrEP that presented results yesterday has generated a lot of enthusiasm. There's some reasons why people may not want to take their medicines every day. Maybe they're not putting themselves at risk every day. Maybe it costs, the medicine costs, and they want to not have to take a medicine every day when they're not putting themselves at risk. And so iPrEP, and this is a schematic from the iPrEP group, was designed so that if you knew you were going to have sex, that between 2 and 24 hours before having sex, you would take 2 pills of Truvada, and then you would take 1 pill a day later, and then 1 pill a day after that. And it generated a lot of excitement because this fall, the Data Safety and Monitoring Board stopped the placebo group. In the study, there was a group that was getting active medications. There was a group that was only getting a sugar pill. And the safety people decided that it wasn't fair and safe to continue to give that sugar pill to people when they didn't know what they were taking. So that arm got stopped, and the results got released yesterday in one of our oral abstract sessions. And of the 400 people who were randomized in this group, equally between the sugar pill and the active drug, there was an 86% reduction in HIV infections in the group that was taking the Truvada. There are a couple caveats in this. One is that there was a lot of risk that was happening in the group that was on Truvada, and so they were taking many pills during a week. So the estimate was that they had taken 10 in the previous 4 weeks, that they had had 10 sexual exposures. And so even though this was a study of intermittent PrEP, this may still be people taking 4 or 5 or more doses during a week, and this may actually, what they've done, be equivalent to daily PrEP. So many people, in looking at these preliminary results that came out yesterday, still recommend that people are taking their PrEP every day. We're not ready to recommend this intermittent idea. In addition, there was a study from the HIV Prevention Trials Network that has a poster at the session in which people do better at taking their medicines every day to cover their sexual exposures. So moving on to, so who is PrEP for? The CDC put together in this guidance a list of basically very sort of broad characteristics of people who might be interested in taking PrEP. This does not mean if people meet one of these criteria, this doesn't mean that they have to. It just means that they should think about it, think about whether they're interested in it, and then talk with your primary care provider about whether it really is right for you.
So counseling is really an important part of this.
Counseling both about what people are doing that put themselves at risk, counseling about the medications and the importance of taking it every day, counseling about continuing to use condoms to the extent that people are using them already, because obviously PrEP does not protect against other sexually transmitted diseases like syphilis and chlamydia and gonorrhea. But in general, if people meet one of these criteria, I would recommend that they think about whether PrEP is right for them. Okay? It's important that someone who starts PrEP be truly HIV negative, because PrEP is only 2 medications and not 3. And it's important that people who are on PrEP have good kidney function, because one of the medications that's included in Truvada can decrease kidney function.
Mm-hmm. And over time, there will be new drugs that will be better tolerated, if you will, and be less side effects that will probably be the best We'll obviously always shoot for a better drug down the line.
That's a great question. Yeah. So right now, Truvada is a great medication, but it has limitations that people have to take it every day. And what you can see on this slide here is that there are some side effects that are associated with the Truvada. Most of it happens in the first couple weeks after people start, that they have some problems with stomach-related, gastrointestinal-related side effects like nausea and bloating. Headache was also reported in this trial. But some of the things that we really worry about are the kidney function impact. That again gets better if people stop their Truvada, but people who have kidney function problems because of other reasons may not currently have a great alternative. And you're right, there are medications, other medications that are being studied currently, like a medication called Maraviroc that's already approved for use for HIV positive people. But there's also injectables and rings and other things that will limit the side effects, provide more ways that people can take it. There are some people who prefer a gel to a pill, and then also have long-acting benefits so that someone doesn't need to remember to take their pill every day if they have a problem remembering.
We're hoping that those long-acting injectables, that 4 times a year or something like that would be really great.
Right, very equivalent to birth control.
But that's a way down the road.
They're currently being studied, but how long it will be before we see results and then see FDA approval in this country, it is probably going to be several years away. Okay. The question often comes up, how long do I need to be monitored? And the recommendation currently is that someone gets HIV testing and STD testing and kidney function before they start PrEP. Very important that someone is HIV negative before they're starting PrEP. And then the recommendation is at least every 3 months to get follow-up HIV testing and to talk with your doctor or your provider about how you're doing with your medicines, whether you have side effects, whether you're taking your medicines every day, and any problems you might have. The recommendation is to get a refill of your medications every 3 months, and then at least every 6 months, although for some people may need more frequent testing. The recommendation is for STD testing, including syphilis testing, and then monitoring of kidney function. The other question that many people ask is about drug resistance and what happens if I get HIV infected when I'm taking PrEP. And the evidence right now is actually looks pretty good. The majority of people in these big studies that had drug resistance were people who started medicines just as they had been recently infected. They had an antibody test for screening, they were in the window period, they started on 2 drugs, and the Truvada won't completely reduce the HIV levels to undetectable. Those are most of the people who got drug resistance. And on this slide, you can see that of the 29, and it's up here, of the 29 people who started Truvada during acute infection, 8 of them actually had HIV drug resistance. This is in contrast to all of the other studies in which very few people ended up who were negative when they started, who acquired HIV. Very few of those people got HIV drug resistance. And the thought is probably the people who are taking their HIV medicines, who are taking their PrEP, aren't going to get infected, so they're not going to get drug resistance. And if you're not taking your medicine and you do get infected, you're unlikely to get drug resistance, although it happens. But you can see here that it's just about, very small numbers.
I think the breakthroughs were mostly in the study. It was mostly people between the time they signed up and got their first test and the time they took their medicine.
Right.
And I'm not sure if there's a way to fine-tune that a little bit. So
yeah,
they might want to be tested 3 days after they take their medicine, something like that.
There are a couple things that people can do to try and prevent this. One, in these original studies that people were being screened by an HIV antibody test, sometimes even an HIV rapid test that has this fairly long window period, the period between when someone is infected and when the test is positive. There's an understanding now that we have much better HIV tests, these so-called 4th generation antibody antigen tests, or even RNA testing that can detect HIV sooner. The other thing to know is that if someone has symptoms of recent infection, the fever, rash, sore throat, muscle-like, flu-like syndrome, that they shouldn't start PrEP. They should get a good HIV test and wait to start PrEP.
Can you say that again, because that is really important for people to know?
Sure.
All the people that are out there, I don't know any that I've come across in recent, because I know we knew that a number of years ago, but it doesn't seem to be, it should be on the top of everyone's list to identify the signs that, and this isn't in all cases, but likely it is.
That's right. So about half of all people who acquire HIV will have some symptoms. Not all of those symptoms that I list, but some symptoms. And those symptoms often get called a flu-like illness, but they often include fever and rash and sore throat and muscle aches. And people often say, oh, I had a flu-like illness. Now, most of the time that flu-like illness is going to be the flu or some other illness. But in some cases, if people have had unprotected sex a couple of weeks before, we want them to get tested specifically for acute HIV infection, that initial HIV infection, and we want them to delay starting PrEP until we really know. Because again, starting PrEP when someone has been recently infected puts them at really high risk for resistance.
Not a good thing.
Yeah. Then finally the question of how do I get this paid for? We've been very fortunate here in Washington State. All of our insurance companies are paying for PrEP. Our expanded Medicaid is paying for PrEP. And in Washington State, we have this great program called PrEP DAP. It's the Pre-Exposure Prophylaxis Drug Assistance Program that is modeled on our AIDS Drug Assistance Program that helps provide Truvada, the medication only, for people who don't otherwise have insurance or have high copays. And I know that many places around the country, many other cities and local health departments are looking at this program and seeing whether or not they want to model this as well. So we're, again, very lucky that the state of Washington has provided this. Our state also has a list of providers who are interested in prescribing PrEP, and so one of the things that we're trying to do nationally is to establish a list of providers who are interested, so people who are interested in PrEP can easily find a provider to prescribe PrEP, because it's harder than you think. And we think that many of the primary care providers are going to be the ones that are going to be prescribing PrEP in the future, and many of them aren't HIV experts and have this comfort level.
So this is an opportunity for those that are watching this program to, especially if they're state officials in another state, to maybe consider checking in with you guys to what you did, and as it's another model that might be worthy of exploring, and of course they'll probably be watching how this rolls out, so hopefully they'll pay attention.
And we'd be happy to share how this was done.
Okay, thanks.
But we're really proud of being here in Washington. So I just want to convey that PrEP isn't for everyone. That PrEP is important for some people who aren't otherwise using condoms for whatever reason, and it's just a piece of the puzzle. And there are other things that you see on the slide that are very important to prevent HIV infection, like HIV testing, like condoms, like treatment for STDs, like making sure that people who are HIV positive have access to care and treatment so that they can reduce their chance of transmitting to other people. So it's just a piece of the puzzle. And as you mentioned, there are lots of other things. We already talked about this slide that are coming in the future. So not only are there pills, but there are gels being studied, vaginal films, vaginal rings, and other injectable medicines, so that everyone who is interested in PrEP has a mode of protection that is that they are able and interested in using.
Or multiple.
Or multiple,
yeah.
Right? Absolutely. So I think that's my slide. And
I really appreciate it. Well, you have information there that we may be able to replicate on the bottom of the screen as well as in the presentation, as it's important for people to be able to contact the right people. And I think if people are in a community like another small city, give us some suggestions of where they might go. And if their government or facilities, medical health facilities, whatever, are not responsive, what would you recommend them do?
Right, and that's tough. I would say I would start with your regular primary care provider. That, of course, assumes that someone has insurance. But the lovely thing about this being 2014 with the Affordable Care Act is that many more people have access to health care insurance. So I would say sign up for insurance if you don't have it already. Have a primary care provider, ask your primary care provider.
Make them an activist.
Make them an activist. It's not very hard to prescribe PrEP. The guidelines, which I believe I have here from the CDC, list out all of the things that a provider needs to know in order to prescribe. There's actually also, which I don't have listed on this slide, there is a PrEP helpline that is funded by the Centers for Disease Control that is at the University of California in San Francisco for providers who have questions about how to prescribe PrEP. PrEP. So there are a lot of resources for providers, but I think it's really about trying to have a conversation with your primary care provider. And I think that many people who are sort of interested in expanding the use of PrEP are going to nationally try to establish these lists so that providers who are interested and willing and able to prescribe PrEP will appear on a national list, just like there is a list for HIV care providers around this country.
Gotcha. Joanne, thank you. It's been a pleasure having you here, and you've been very enlightening for our audience, and hopefully they'll tune into this, maybe review it, use it as a reference, or pass it on to their friends, because PrEP is an important piece of the armamentarium now.
Thank you for having me.